Welcome to another ultrasound of the week. I'm Dr. Michael Schick. Thank you for joining us. This week we have to give credit to our own Susie Ondak, who recorded this beautiful ultrasound you're about to see. A middle-aged man came into our upfront care area, which is like a fast-track area, complained of pain while playing basketball. He said it felt like someone had kicked him in the leg, and initially that's what he thought happened, but he also heard a pop at the time. He found it difficult to walk, and then he realized that the same thing happened around 2 or 3 years ago, but occurred in the contralateral leg. On exam, his posterior inferior leg demonstrated edema, ecchymosis. It was tender diffusely along the gastrocnemius muscle and Achilles tendon. He was able to dorsiflex pretty well, but it was very painful, and had some minimal plantar flexion as well, but it was limited by pain. We performed a Maytals test. That's when you have them lay prone and the patient lift their knees 90 degrees flexed. And you should see some reduction in plantar flexion if there's an Achilles rupture. This patient had about the same amount of plantar flexion, and we suspected it was because of this old injury he had in the contralateral leg. The Maytals test is about 88% sensitive for ruling out an Achilles rupture. However, the sensitivity does decrease as the time from injury increases. We then performed a Thompson test, which according to some studies has a sensitivity of 96% to rule out Achilles rupture. You have patients lay prone, you have their feet hang off the bed, and you squeeze their calf, their gastrocnemius, to see whether you can induce plantar flexion. If there's none, very likely they have an Achilles rupture. Now, 5 additional things to keep in mind when we're talking about Achilles rupture. Some of these were taught as hard and fast rules, but it turns out that some can walk and some can't after Achilles rupture. Some can retain some plantar flexion because they'll have other muscles like the soleus that can participate. Some have a palpable gap, but some won't. Some have a positive Maytals test and some don't. And finally, some will have pain and some don't. According to at least one study, a third of patients didn't have significant pain, and a lot of the practitioners played down their complaints because of it. So if the diagnosis is unclear, you have a couple options, ultrasound or MRI, to further evaluate, and this choice is a no-brainer as far as I'm concerned. When evaluating tendons, you want to look at them in both the long and short axis, but the long axis is a little bit easier to evaluate them in. You want to see where they insert into the bone. You want to evaluate the striations of the tendon to make sure there's no discontinuity of it. You're looking for edema within and around the tendon, to look for tendinitis or signs of inflammation or hematoma. You can put color flow on there to see if there's increased vascularity. Also, hyperechoic spots that shadow are often calcified parts of the tendon or calcinosis that indicate previous injury. Lastly, always compare to the contralateral side. Comparing normal anatomy will really help you make the diagnosis. Interestingly, when we looked at this patient's Achilles tendon, we could see the calcaneus easily, and you could see the tendon inserting into the calcaneus. We expected to see just hematoma there, a complete disruption of it. It didn't look quite normal. It's not perfectly homogeneous. There does seem to be some edema within it, but as we tracked it up the leg, we saw a lot of hematoma, and then we saw an area that we thought was a complete rupture of the proximal tendon. And when we applied a dynamic Thompson test with ultrasound, we could clearly see a complete rupture of the Achilles tendon.